Hello, I'm Monica Kasting from Purdue University, and I'm going to talk about our article that was recently published in the American Journal of Public Health titled County Level Factors Associated with Influenza and COVID-19 Vaccination in Indiana, 2020 through 2022. As a brief background, the COVID-19 pandemic highlighted rural-urban disparities, including access to healthcare, differences in health beliefs, higher vaccination hesitancy, and lower vaccination confidence. While initial pandemic hotspots centered in densely populated urban areas, infections in rural areas began to rise as the pandemic progressed. Nationally, there are significant rural-urban vaccination coverage disparities across multiple vaccines. Addressing these disparities must begin with accounting for the triad of local culture, geographic location, and economics of the region. Therefore, this study aimed to assess existing differences among adults in both COVID-19 and influenza vaccination by county in Indiana and determine what county-level factors are associated with those vaccination rates. We chose to focus on these two vaccines because they both involve respiratory viruses, both have generated greater vaccine hesitancy than other adult vaccines, and are both routinely recommended for all adults. We used several sources of data for our analyses. We examined COVID-19 and influenza vaccination rates across Indiana's 92 counties among adults aged 18 years and older from December 2020 through March 2022. For COVID-19 data, we use the Indiana State Department of Health's Immunization Registry, which is called the Children and Hoosier Immunization Registry Program, or CHIRP. CHIRP had mandatory reporting for all COVID-19 vaccinations. These data are publicly available by request. CHIRP also includes information on county-level vaccination rates by age group, race, ethnicity, and sex. All data were aggregate and no individual-level data were available. However, there's not mandatory reporting in CHIRP for adult influenza vaccinations. Therefore, for flu data, we use the CDC's U.S. Influenza Surveillance Dashboard, or FluVaxView. FluVaxView reports weekly national influenza vaccination data by county. From the database, we extracted influenza vaccination rates using the Federal Information Processing Codes, which are unique codes assigned to each county in the U.S., and we filtered down to only Indiana counties. For our other measures, we derived population-level estimates from the U.S. Census. We also included county-level sociodemographic and health data from the County Health Rankings Report, which is supported by the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. From County Health Rankings, we extracted data on sociodemographic distribution of each county, including median household income, percent of the county that's rural, and percent of the county that is Hispanic, among others. We extracted data on health indicators like the number of primary care providers per capita and the percentage of the population who smoke. And we also included information in our analyses about whether community paramedicine programs for rural vaccination outreach were available in each county. Our data analyses started by describing the sample using means and standard deviations, or median and range, for all county-level variables, as well as vaccination rates. We modeled county-level vaccination rates using linear regression weighted by the total adult population in each county, and then conducted model selection using forward, backward, and stepwise selection to determine the best multiple linear regression model for each vaccination rate. We selected the best model based on the adjusted R-squared value and examined tolerance values for variables in each final model to ensure issues with multicollinearity were negligible, and we assessed residuals for normality. The selected reduced model for each vaccination rate is reported, and the squared semi-partial correlation coefficient for each variable is reported as a measure of effect size. You can see the mean percentage of counties that were rural was 54.5%. When looking at sociodemographic characteristics, the mean percentage of residents who were African American were 3%, with a wide range from 0.2 to almost 30%. There were high rates of smoking, with a mean of 22%, and obesity, with a mean of 36%. The mean COVID-19 vaccination rate across the 92 counties in Indiana was 58% and ranged from 31.2 to 87.6%. The mean influenza vaccination rate was 42.9% and ranged from 33.7 to 53.1%. This figure displays the variability in COVID-19 and influenza vaccination rates across Indiana counties, with darker color indicating the higher vaccination rate. COVID-19 vaccination rates are shown in panel A on the left, and flu vaccination rates are shown in panel B on the right. As you can see, there is more variability with COVID-19 vaccination than with flu vaccination, and overall flu rates were lower than COVID-19 vaccination rates. The final selected model for COVID-19 contained 7 variables and had an adjusted R-squared of 0.867. Based on this model, an increase in primary care providers per capita, median household income, percentage of Medicare enrollees who had a mammography screening, and percentage of African American residents were all associated with increases in the percentage with COVID-19 vaccination. In addition, an increase in uninsured residents, percentage of female residents, and percentage of people who smoke were all associated with decreases in the percentage with COVID-19 vaccination. The final model for flu contained 5 variables and had an adjusted R-squared of 0.702. Based on this model, an increase in the percentage of residents who were uninsured and those who completed high school were associated with increases in the percentage with flu vaccination, and an increase in the percentage of African American residents, Hispanic residents, and percentages of adults who smoke were all associated with decreases in the percentage with flu vaccination. While both COVID-19 and flu vaccinations are routinely recommended for all adults, county-level factors associated with each vary greatly between the two vaccines. The reduced model for COVID explained a slightly higher percentage of the variants, 86.7%, than the model for flu, 70.2%. This may reflect greater polarization surrounding COVID-19 vaccination, leading to a greater influence in sociodemographic factors with COVID-19 compared to flu. Of note were variables reflecting access to care, like the number of primary care providers per capita, which were significant for COVID, but not for flu. One possible explanation is the unique way in which the COVID-19 vaccine was rolled out, which involved different dates which people were eligible based on age or occupation, for instance. The need to sign up for a vaccine online, and difficulties, particularly early on, in finding available appointments, all of which may have increased logistical barriers and resulted in the differences we found in our data. Another finding of interest was the association between each vaccine and county-level racial ethnic distribution. The percentage of Hispanic residents in the county was associated with influenza vaccination but not COVID-19, and the percentage of African American residents in a county was negatively associated with flu vaccine but positively associated with COVID-19 vaccine. This could be due to targeted outreach programs, persistent medical discrimination and distrust in the medical community, or a broader reflection of access to healthcare. It's possible differing findings by the Hispanic population may be better explained if we controlled for individual patient characteristics. That was not possible with our aggregate data. Future research should explore these racial ethnic disparities while taking individual patient characteristics into account. Importantly, smoking was strongly negatively associated with vaccination rates for both vaccines. This may seem counterintuitive because smoking is a risk factor for severe respiratory diseases. However, research shows preventive health behaviors cluster together, and people who engage in one healthy or unhealthy behavior are more likely to engage in another. Likewise, people who smoke are less likely to receive routine preventive services. In addition, while the percentage of the county that was rural was significantly associated with both COVID-19 and flu vaccinations in univariable regression analyses, these associations were no longer significant when other variables were included in the model. It's possible that the rural-urban differences were accounted for with other county-level factors, including income or smoking status. But the reasons for the rural-urban disparities across a multitude of health indicators are multifaceted and are likely a complex combination of access, infrastructure, attitudes, and beliefs. Our findings should be interpreted in the light of some limitations. First, the data are cross-sectional and causal relationships cannot be established. Second, the data are aggregate and are subject to ecological fallacy. In addition, our data focused only on Indiana and findings may not be applicable to other states or jurisdictions. And lastly, because CHIRP does not track adult influenza vaccination, we use 2 different data sources to examine the 2 vaccination rates. It's possible that the 2 data sources differ in their accuracy and reporting. Therefore, the results of this study should be interpreted with caution, and further studies are needed to understand the complex associations between systems-level factors we examined and vaccination rates. In conclusion, while both COVID-19 and flu vaccines protect against respiratory viruses and are recommended for all adults, the factors associated with uptake of each are varied. Variables reflecting access to care, like the number of primary care providers per capita and median household income, were significant for COVID-19, but not flu vaccination rates. The percentage of uninsured residents in the county was significant for both vaccines, but in opposite directions, so that the rate was negatively associated with COVID and positively associated with flu. The polarization surrounding COVID-19 vaccination may have led to a greater influence of sociodemographic factors with COVID-19 vaccination as compared with flu vaccination. Further research, including individual level data, is needed to better understand these associations and develop effective interventions to address county level factors and improve vaccine uptake. In closing, I'd like to thank the rest of our research team and acknowledge our research support and funding for this work. Thank you for your time. For more information, please view our full article by scanning the QR code.